Okay, welcome to the Rule Breaker Studio. Kelly, we're so excited to get to chat with you today, and I'm so excited for what you're going to share. Just knowing your background as a nurse and an engineer, I have to say, I was just interested and I reached out to you because I was like, oh, she's a nurse, she's an engineer. What kind of voodoo is going on here? I need to know about it. So I'm so excited that you took my message and reached out, and we're here today on the Rule Breakers podcast. So I'd love for you to just jump in and really just share with the listeners about who you are, and then we'll dive into conversation.
Well, thank you so much for having me. I'm very grateful that not only you ran across my profile, but that you reached out. I am a nurse and an engineer. The nursing part is still relatively new for me personally, but I always like to start by telling people that I was raised by a nurse. And my aunt was a nurse, and other family members were all in the healthcare field. And my dad was an engineer. So I have not exactly strayed too far from the path of where I started. I started out in biomedical engineering with a long path to get there. Um, and I loved that job. I didn't leave engineering. I like to say that I added nursing. But as a biomedical engineer, I did predominantly what I call patient care devices. So a little bit different than what some of my colleagues were doing, which were more, I would say, kind of like a one-to-one consumer with surgeons. So in that job with these patient care devices, they were predominantly nurse-led types of innovations. And nurses were end users, patients were end users, the environments were all different. So it was really complicated. And unfortunately, no matter how hard I tried, or my team tried, or we tried to figure out what was going on, we never quite got it right, which is what led me to go into nursing. I went across the industry, asked questions, tried to figure out how we can make things better. And the advice I got from people was that to change the system, you had to be in the system. And so in 2020, I ended up getting my degree in nursing, and have been worked on the floor as a nurse in different areas for almost 3 years. And then after that, I had the opportunity to start tying things together from a workforce lens. And then about 6 months ago, I started a role also with the American Nurse Enterprise, working with nurse innovators to really try to continue to move the system forward and help nurses own their practice from end to end.
You're speaking to something so relevant. I can see Alyssa's excitement too. Just we try to move all these things forward and we don't have the people actually doing the work in there. But I'm curious, now you've gone through it all. Do you agree with what people said? Like, you've got to be in the system, or can we bring in people from the system to help move it forward?
That's a fabulous question. I'm going to just give a little anecdotal story to allude to sort of some of the resources that I think are needed. I like to tell the story about a syringe, right? It's a pretty basic device. And as an engineer, I helped design the injection molds for these types of products. I knew, what materials were there, what forces were required. I mean, it's a syringe. I don't know what more to say to that, right? Technology is pretty well developed. But I'd actually never used a syringe until the first time I flushed my patient's catheter with saline, mind you, nothing extraordinarily risky in that solution. And I will tell you, that's the first time I ever really understood what it was like to use a syringe, or what a syringe was. And I have reflected on that experience in multiple avenues. But really this realization that as an engineer, I was using a subset of my senses to develop products and to learn things and to use a syringe. But once you're in that context, you're in the system, you're in the environment, and you know the cognitive load in the nurse's mind, what the patient is experiencing, what they've been through, you're suddenly now experiencing that same syringe with all of your senses. And so I bring that up because the answer is it is all of the above, right? We work in complex adaptive systems, so we need nurses, we need engineers, we need every discipline. But what I have learned is that we also need people that can help translate. And so lots of times when I will be talking about something with a nurse or an engineer, they think they're talking the same thing, right? Nurse and engineering processes are incredibly similar, but oftentimes because all of that context is missing, we're actually saying very different things.
I have chills, chills. So when I think about your work and what you're saying, yes, we work in complex adaptive systems, and how do we bridge the conversations? How do we bridge the communication? Because I think, that's what, when I thought about your role, right? When I thought about, oh, here's this person who is a nurse and is an engineer and has fused these two backgrounds, I thought about what are the possibilities of how you can communicate needs across a system with a person who can explain it from a practice standpoint and a practicality of, invention and development standpoint. So, because I think about, you have these opportunities where you're evaluating products, right? And you bring a product into the system, and by design, yes, it's great. And then you go to implement it into practice, and the nurses are like, yeah, but it's too big to fit where we can actually go get it and use it. And so we don't use it. It's a great product, but we don't use it because of accessibility issues, or because I have no way to carry it, or, I don't really have the time to go all the way down the hallway where it can be stored and that kind of thing. So it's just, even thinking about that, we had talked with someone who did healthcare system design. And I just think about how you bring all of these people together and how you can really adapt a whole workforce to different processes. So I would love for you to just maybe share a little bit about, is there a situation where you've been able to kind of fuse those communication points and bring people together to have a successful project, or what you would consider success in the healthcare system in one of these complex adaptive systems?
The long answer, or the short answer to the long background, is I don't think that I could define one single success. And I think that's a lot of what I'm learning about a complex adaptive system, is that unlike a lot of the things that we did in engineering, there is no one predictable future, right? There is no one right answer. And I think that's a lot of why we've struggled to define these projects, right? We do these pilots, we try to scale them, we try to take them into different places, and they don't necessarily always work. I was listening to a podcast recently, and someone talked about it as contextualization versus conceptualization. So we have these sort of high overarching principles, and then they like a global level, and then you take them to the local level, and quite possibly everything is different at that local level. So I can give you a few examples of where we were able to bring people together to change the course of projects. But really this lens that all these pieces are connected. So we talk about products, and I like to say that products are embodiments of processes. And so if a product does not support the workflow or the process, it becomes the process. And so when you bring people in to see problems and they don't see the entire context of the problem, the solution is kind of doomed for failure from the beginning. So one of the opportunities I had when I was a nurse on the floor was to reach out to a quality improvement engineer that was working with our unit and the unit council. And the issue that they were, discussing at that time was CAUTI. And so I really wanted to dive into that issue and figure out what exactly was being done, because I had seen it from an engineering lens, but didn't quite understand how that played out in the healthcare setting. And what I ended up learning was that there was a whole audit system going on the floor that the nurses on the floor did not even know was going on, right? Like someone else was accessing their charts, looking to see whether they had documented different things. And then that was related back to the CAUTI procedures. And then there was education being given like separately. And then things were supposed to like come back and suddenly be improved. And it was very disjointed. And the solution was more education for nurses and then more audits. And to that person's credit, the quality person, I said, just come follow me for a morning, right? I'm new, so it was a little bit of a risk. I'm new to the game, but come follow me, come watch what I do. And that person did. And after about the first 10 minutes, when I had described what was happening, when I say in engineering speak, so here's what we thought we were going to do. Here's what the procedures say we should do, and then here is what actually happened. This person just looked at me with eyes wide open and said, "Oh, I get it. I get it." And so the relationship after that evolved, and we actually put into place a very small intervention on the floor, but even just to raise the awareness, and that was a sticker on the Foley bag, right? The first thing that you always look at least that I looked at when I came into the patient's room, was sort of this unsightly Foley bag hanging on the side of the bed. It's hard to miss. It's one of those things that kind of just always garners your attention until you've taken care of it. And then, of course, you get distracted by an unknown number of other things. And you have to keep coming back. And then there's the charting of it. And so the sticker was really just bringing people's attention back to what are the things on this audit, in a place where, you don't have to access the computer. You don't have to click through 10 different screens to record and document everything. It's just a simple, basic intervention that is a communication that's aligning these standards versus the context. And so that intervention was being put in place when I actually moved on to a different role. But just the concept alone and talking about what was going to be on that sticker and the places on the sticker and that level of understanding for that one project with that particular individual in QI changed the whole relationship. And so when they approached projects, they came first and asked, tell us what the nurses are doing, right? Tell us what's working and what's not working. And that change alone, I think, not only built stronger relationships between the different areas that have pieces of the solution, but opened up those avenues for innovation where people were given permission to think differently.
Okay, so two things that I have to call out. One, the little golden nugget there that you reframed the conversation and reframed an entire thought process from reaction to proaction, and how that is, that it probably has transformed even more things since you've transitioned out of that position. But moving from, okay, this is what you're required to do, and we're just going to react and re-educate, and we're going to re to, okay, now I'm going to assess what is actually the process, how is it actually functioning, and then what are the fallouts in the process, and be proactive in terms of how you address those challenges. So I love that little golden nugget that came out of that example. And then the other thing I just wanted to mention is the courage, right? You gave some courage in saying, hey, come follow me. Instead of going back and forth about why a process isn't working, hey, come follow me and let's look at it in real time. Let's look at how it actually affects my day-to-day work. But I think there's a little bit of apprehension sometimes with nurses because you don't want to be watched, right? Like, don't watch me. Even though you're doing good work, like you're doing the right things, sometimes you've had to find or develop a workaround, right? Because the process doesn't work for you, doesn't work for your system, doesn't work for your patients or procedure or product or whatever, you may be dealing with. And so I think those two things were just really stood out to me in what you shared. And I just wanted to call those out for other people who may resonate with that. But having that courage to say, it's okay, come follow me. I'm not perfect, but I think we can learn something from each other in this process. So I appreciate you sharing that. That was awesome.
I know. For me, the thing that stuck out was it's funny how the lowest level of intervention of anything you can do to solve a problem is education. And that is the first thing we slap on it, is education is going to solve it all, right? But what you said, and I think honestly your whole career journey, the person with the solution is typically the person closest to the problem. And someone earlier that we spoke to, Alyssa and I loved it. I'm going to use this multiple times. If there's a nurse around, there's a workaround. And I loved that. And you also called out audits. We've got all these audits going on. Like an audit is this magic solution, right? Or this heavy gun that we're going to be like, well, you didn't do this. You didn't document these in the right places. None of that says that the care being provided isn't great. There's something broken with the system. And I love that we just welcome in the other perspectives. And you've perfectly blended two industries together, which we fail to do in healthcare oftentimes, is we stick within our own. And there's so much to be learned from one another. So I love that you welcomed that person in to really see, oh, now I understand. It's not we're digging our heels in saying we're not going to do this, but we just go back to as if their solution was right. Let's re-educate. There's something wrong. If it's not getting done right, there's something missing.
Thank you for highlighting that. And I should point out, one of the things that was a major driver for me adding nursing to my background was that as an engineer, I could no longer put clinician training as a risk mitigation. All I could think to myself is, how can one person remember all of these things? So that was a huge push for me to try to figure out how do we align these products that can support processes in these complex environments. One thing that I would love to point out is an area of thinking that I've been embracing pretty significantly since I went into nursing, and that's an area of safety engineering that is coming out of MIT. So the woman's name is Nancy Levson, and she has a couple of books, but this process called STAMP. And I call it out specifically not only because I think every engineer and nurse should embrace looking at it, but the words in that book were able to really just transform my thinking. So two different things that I want to call out from that is that, one, human behavior is a context of their environment. So no matter what education you give someone, if you put them in two different environments, they may behave in two completely different ways. And then the second is that safety, which I know is paramount for both nurses and engineers, is an emergent property of a system. And so these linear methods that we used in engineering, whether they were failure modes and effects analysis, or the concept that we could design processes by making products, is fundamentally flawed. But also in healthcare, thinking that that every single event is so unique that we are unable to use different engineering methods to try to eliminate those failures. They're like two separate polarities, right? And neither one of them are true in a complex adaptive system. It takes the people and the processes to really lead to all of the outcomes. So it has been a journey not only about professions, but about relationships and about really, being able to understand how we behave as a result of our environment and what creates that environment. And there's a lot to be garnered from the history of technology and nursing in general as well.
You said two things that I want to say. First is I love that you said it's not linear, but at the same time, gosh, there's such an opportunity there because we do say it. Well, it's different at my department. It's different in my organization. And yet, if we would embrace some of these things, we're not as different as we think that we are. But again, it's not a one size fits all, but there is something valuable there. But my favorite thing that you said is the environment. You can take the exact same person and put them in two different environments and have incredibly different outcomes. And I remember a story that Simon Sinek told about being a customer at the barista at one hotel, and ran into that same barista at a different hotel and encountered two entirely different people. And it was all about the leadership that impacted that individual. And so in this particular instance, I'm going to come here, I'm going to put my head down. I'm not going to go above and beyond. I just don't want to get in trouble, stay in my lane. And over here, I feel valued, seen, appreciated, heard, and I use my voice. And I'm so excited to be at work and try to make a difference. And I think there's real power in noting that.
Absolutely. So Kelly, I think you have shared some of my favorite pearls of wisdom today. I have to just say that. It has been a wonderful conversation. However, we did bring you on to the rule breakers. So we have to know, if you are breaking any rule in healthcare, what rule are you breaking?
Definitely who's on the bedside team.
All right. What about that is something that you would be specific about wanting to break?
Engineers, I think for sure, should be the first people that come onto the bedside team. Having worked across industry in multiple different ways, engineers serve a multitude of purposes, but just improving the environment. I mean, if you were to compare, say, a workflow as an engineering process, in industry, you've got people assigned to looking at changes, to looking at the impact of changes, and their goal is to account for that and to decide whether the system is still meeting its needs or not. As it stands in healthcare, that if that function does exist, it typically is so far removed from the actual process that it's not able to be effective in the time frame that's necessary.
Oh man, I want to add to that. There's not, and then when we do bring the engineer into the system, like you said, the far removed, oftentimes we create these committees and things with them, and it's the leadership that's representing rather than the person doing the actual work. And so we're just not hitting the nail where it needs to be. So I love that.
Yeah, I like that you said bring them to the bedside team, because I think that's where it has the most value to really change the lens and the landscape, right? So if anyone wanted to connect with you and they wanted to follow up after this podcast, or they wanted to reach out to you for any kind of conversation, where's the best place for people to find you?
The easiest place for me is the website, nurseengineer.com. Easy to remember, and any of the links you can click on, and your voice will come to me, and would love to continue the conversation and learn more about how you're looking at this, how you're fusing these roles together. There's a lot of precedent. There is a lot of opportunity, and truly believe that we are better together.
Love it.
Well, it has been a pleasure to have you on the Rule Breakers podcast, and I'm so excited to welcome you to the Rule Breakers Club. And again, thank you so much for your time.
Thank you. Appreciate it.